Thank you for being here today. I'm Marisa. I'm one of the criticalists at the Ralph. I am recently new in the team, but I'm very, very grateful to be part of this amazing service that we have there. And I've been invited to speak to you tonight. And I was actually the one who chose this topic because I think it's quite common for you to face patients in shock as general practices. You actually tend to be the first line of these patients before they get escalated in their care. And I know that they can be very scary sometimes to deal with. So hopefully tonight, I'll make you a little bit more comfortable dealing with them. So I'm going to start by talking about Pistachio. Pistachio was a puppy that presented to us, not at the Ralph, at another institution that I was at. He came wrapped in a blanket. He was unresponsive, but we saw that he was breathing. And just by touching him, he felt really, really cold. And just by looking at him, we estimated that he was about 1 to 2 months of age because he was so petite. As you might imagine, everybody starts working on him really hard. The first thing that we try to get into a patient that presents like this is IV access. And as we were trying to achieve IV access, Pistachio suffered cardiopulmonary arrest. And now, if anybody wants to know what's going on, what might have caused this, why is he so sick? Well, not only they have no money, but they also don't speak your language. So it's what you got. The worst case scenario. You have a patient in arrest, you have no idea what just happened. They also don't have a lot of money, so good luck. So from these, I would like to ask you, and please let's remind ourselves that we are in a safe space tonight, at least. We should always be in a safe space, but there is no wrong answers or comments. I just would like you guys to participate as much as possible. So when I look at a patient like this, the first thing that I would like to ask myself and you guys is, do you think that Pistachio was in shock? Who says yes? Who says no? Who doesn't know? Okay, the majority agrees Pistachio was probably in shock. And what do you think that led to him suffer cardiopulmonary arrest? Yeah, poor cardiac output is an option. Any other options? Hypovolemia. What else? Hypoglycemia. He's a little puppy. Yeah, basically anything that could have decompensated the shock that he presented with. And that shock was just too fast for us to act on it. And can anybody tell me what is his prognosis at this stage? We have a vote for poor. Okay, who thinks he's grave? Who thinks he's good? Who doesn't know? I don't know. He's a little baby. He just arrived here. He's super sick, and I have no idea what's going on with him. If you guys have children, or if you guys have human doctors, and if a child presents to the ER, like Pistachio did, and suffers cardiopulmonary arrest, if you ask those pediatricians, what's this child prognosis, what do you think they'll tell you? Do you think they'll say, I think he's poor? This is futile. They don't even think about it. It's a child. They're going to be doing CPR for hours, sometimes for days. They're not going to stop. So I think that's very inspiring. And that leads me to the last question, which is, can we still save Pistachio? Yes. We have some people that say yes. Who doesn't think we can save Pistachio? Who doesn't know? I don't know. But I'm going to say that I really want to believe that, yes, we can. So let's try, okay? That's what we're going to do. We're going to try. And so Pistachio, despite being so unlucky that night, he was fortunate enough that he was surrounded by a team that got hands on him right away. We started thoracic compressions. Obviously, just to make our life even harder, he vomits or regurgitates a ton. Nobody can get airway access. Eventually, we can after suctioning. Now he's intubated. He's being ventilated. We do 2 rounds of drugs. Anybody wants to do something else for him at this stage? We achieved IV access.
A fluid bolus?
A fluid bolus, maybe. Why?
Assuming hypovolemia, which is not proven at this point, but
Yeah.
is a likely.
Yeah.
If it's a cardiogenic shock, then we will lose the patient if we give bolus.
Correct. Now,
To identify the shock type first.
yeah. Well, but he's already in arrest, and this is now where we're going to be dealing with this dilemma. A colleague is going to say, give it a fluid bolus, and someone is going to say, have you ruled out heart failure? Very fair. So here we're going to play probabilities. If you can squeeze a little T-POCUS, point of care ultrasound during CPR, maybe I can take a peek at the left atrium, and maybe I'm going to say it looks pretty small. In this case, I went with probabilities. He's a very small puppy. He just arrived already cold, peri-arrest. Most likely, he's dealing with some sort of vomiting and diarrhea, because that's what the majority of puppies do. But yes, you're very right. He could also be in heart failure. But we have gone with probabilities, so he's gone fluid boluses. Do you want to give him anything else? Yeah, glucose. Perfect. So he's gotten some glucose as well, because he's so petite and he's a little baby. So I'm just going to assume that he's hypoglycemic. So we've done that. Okay. And guess what? We managed to get Pistachio back in this world. So this is Pistachio just a few moments after I extubated him. Don't know if we have sound. Do we have sound? No? Okay. Oh, maybe just here. It's just me talking to him anyway. It's not important. So the poor little guy is coming back to life. Things are looking a bit better than when he arrived. And now from here, we're going to give him more time. We're going to keep working on this patient very intensely, because even though we achieved something good, he is still very much at risk and still very much fragile. Okay? This is Pistachio a few hours after his cardiopulmonary arrest. Still not quite with it, but getting there. He got a central line on his neck now. He deserved it. He's still on the table because we're still too scared to put him away in a cage. We don't trust him. So he's just showing us what he can do. And he was admitted into the ICU. We tested him for parvo. He came back as negative. We didn't really care. We treated him for parvo anyway, because that's what we do, right? And he was fine. He was totally fine 5 days later. He actually was lucky enough to get a new family that could afford his care. So I know that he's still these days a completely normal dog, adult now. This was him just before he went home. He was already puppying, as I like to say. He became a puppy again. You know, and we were very happy. But what Pistachio tells us all is that he was super, super lucky to be one of the few that we were able to send home. The majority, we are not once they suffer cardiopulmonary arrest. So once we get a patient that comes in shock, we need to be quicker than that shock, because even though this is possible, it's very, very hard for us to achieve. So when we think about shock, what does that mean? I always hear this. The patient is in shock. My interns, not so much our interns here, but in America, the patient is in shock. Okay, what does that mean? It's in shock. And they couldn't come out.
To the violence.
Yeah.
Low perfusion.
It's one of the descriptions, yeah. Any other suggestions? We're pretty close to going down to the bottom of the question, which tends to be related with oxygen demand. But it's what you're saying, either because the perfusion is not good. The only thing is that there are other conditions that are not necessarily depleted in perfusion that can impact oxygenation. But basically, when we talk about shock, we talk about a state where the oxygen supplies to the cells is not enough for the metabolic needs of the body. And initially, we have quite good compensation mechanisms, and we're able to cope with that. Our body has these, let's say, reserves to deal with that. But those reserves are not endless. So if we have prolonged shock, that's when those reserves are depleted and start failing. And that's when we start dealing with multi-organ failure, and eventually that leads to death. This is a very annoying slide, but I think it's very important, particularly for the doctors, because when we have Pistachio in front of us, we need to be able to see a bit more than what we are just looking at. It's more than a dog. What is going on inside of the body of my patient? This is what's going on inside of the body. And every single step of this diagram is what will lead to that cardiopulmonary arrest that I need to avoid so intensely. And it all starts with inadequate perfusion, particularly in cases of hypovolemia, like it was his case. And if I don't have enough perfusion, the blood doesn't reach all the cells, so they don't receive the oxygen that is being carried there. And if they don't receive the oxygen, they switch to anaerobic metabolism, right? And then we start producing lactate, the lactate that everybody likes to measure. Lactate is not necessarily bad. The problem is that it drags the hydrogen with it. And so we then have acidosis installed. And that acidosis initially, during the compensation phase, will create vasoconstriction. And that's good, because that way the cardiac output is maintained. But as time goes, there will be failure of the precapillary sphincters, and then we start having a pool of blood in the venous circulation. And that's when we have decompensated shock. On top of that, what the metabolic acidosis is also going to do is impact the cell function. If you guys remember how the sodium-potassium channels work in the cell membrane, maybe you don't, you already forgot, who cares? Well, the only thing you need to remember tonight is that metabolic acidosis will impair those pumps. And those pumps are really precious to say. You go outside of the cell, you come inside of the cell, whether that is electrolytes or any other components. If that balance is disturbed, it leads to a catastrophe, basically, because we start having leakage of toxic substances into the circulation. That's going to affect the endothelium, which is the inner layer of our blood vessels, and it leads then to continuous injury and multi-organ failure. Okay? That's what is happening every time that you have a patient like Pistachio presenting to you. And we need to battle each one of these steps very quickly to avoid things to progress. So, recognizing a patient in shock sometimes can be also challenging. Is this patient in shock? She was just brought in. She's in the ER right now. Is she in shock? Who thinks she is in shock? Okay. Who doesn't know? Okay, I will help you all. Who doesn't think she is? She's in shock. Here you have a monitor, and we'll go through the monitor in a second. But first, I want you guys to look at her body posture. Okay? This is a pit bull. She was just brought into the ER table. She is laterally recumbent. She has an IV already placed. She has clips on her skin, which are a little bit annoying. She has a cuff. She has a ton of tubes. She even has the pulse ox on her lip. Her eyes are just staggered at the horizons or somewhere, and she's not moving. I don't need any more information than this. This patient is a massive emergency. It is in shock. Now you ask me, which type? I don't know. I have no idea what's wrong with her. But her body posture tells me that I need to be very quick. If you as a doctor see a patient like this, you need to approach her, and you cannot leave until you better assess her. And our nurses, because I know that some nurses are here, not just the ones that I work with, this is the patient that equally you need to get all your monitoring on top and start quizzing your doctor that might be distracted. What do you want me to do with this patient? Do you want a fluid bolus? Do you want this? Do you want that? Do you want that? We need to start working on her really, really fast. And then if we look at her values, they are a little scary. I'm trying to pause the video there, but it might not be possible. So if you look at the heart rate, 188, massive tachycardia. She's hypotensive with systolic of 76, mean 57. The SpO2 is saying 78% just now. It's possible, but she's so poorly perfused at this stage that it's probably also not reliable. And she's tachypnic. Why do patients in shock tend to be tachypnic even if they're not dyspneic? Compensation. And what does that lead? Let's say, how do they compensate? By breathing faster. What does that cause? Expelling CO2. They expel more CO2, so they battle against the metabolic acidosis, and they get more oxygen. Exactly. They breathe faster, they inhale more oxygen to compensate for the fact that they're not oxygenating well enough. So if we receive a patient like this dog, and we say, this dog looks like he's in shock, go back to the basics, particularly if you're a person that is not very comfortable with emergencies, starts hyperventilating, oh my God, it's real sick, what do I do now? Take a step back and go back to the basics. Remember your A, B, C, D, E approach. The E is for humans and tends to be related with environment, just for the doctors to make sure that it's safe, I don't know, to start doing mouth-to-mouth ventilation. We don't really tend to worry too much if it's safe or not to deal with our patients, if they're in shock, that we're not getting exposed to a substance or something like that. So I like to replace the E by U, and this is to remind us that urinary system integrity and function is going. Because what do we tend to see? We tend to see compromise of the airway, of the breathing, of circulation. Disability goes for mentation, okay? So if your patient has abnormal mentation, your patient could be in shock. And if your patient doesn't have a functional and with a good integrity urinary system, he will very easily go into a variety of shocks as well. And we see this a lot, isn't it? Blocked cats, blocked dogs, uroabdomens. So check that you have all of these screened, and if there is one that has an abnormality, stick with it. We need to resolve it to avoid cardiopulmonary arrest. If we talk about extra information that we can take to assess these patients, everybody loves a history and medical records, particularly in referrals. Everybody wants to see what has been going on. How many years ago did he get vaccinated? Nobody really cares right now. It's the answer that's so unhelpful, right? And yes, you can ask the history to the carer. I would encourage you that this is when you should practice to get them to be brief, which can be so hard because they want to talk to you. Oh my God, you have no idea. And like last week, doesn't matter last week anymore. What happened today? When did you see him starting breathing like this? I need to go back to him right now. So I need you just to tell me how many hours ago did he start breathing like this and what happened in that moment. So they focus, they tell you, interrupt and say, thank you. That was very useful. I need to go back to him now. We'll then chat again more lengthy. And you run. Nobody cares 2 weeks ago, 2 months ago, the blood work from 2 days ago. Not important right now if he's in shock. All it matters is now, okay? So yes, history is good, but it's the physical exam and the perfusion parameters that we need to focus on right now, all right? And this is quite basic. Also, cheap. We just need our hands, our stethoscope, and our assessment, and we can immediately start getting a ton of information from our patient. The perfusion parameters are core, but then never forget about the breathing and the mentation. Moving on then to diagnostic tools, we also don't need to be super expensive to assess initially the patient perfusion or oxygenation status. So if I think about perfusion, I say I would like to know his lactate, and I would like to know his blood pressure. You can argue, well, you can go with your pulse. Why is pulse not good enough? Let me put it this way. Why is pulse so specific but not sensitive? Meaning, if I don't feel a good pulse, it's probably real bad. But I could feel a decent pulse, and this patient could still be hypotensive. How's that?
The heart is compensating for the...
Not necessarily.
If the shock is septic, so there's like vasodilation and the map is very light?
Could be. Let me put it this way. When we feel for a pulse with our hands, right? Also not super sensitive. But when we feel, what we are feeling is the difference between the systolic and the diastolic. So if they're both very low, you will still feel a good difference between one or the other, right? Because that's all you can measure. But your patient might be hypotensive. The same as if they're both very high, you're not going to feel super strong pulses. You might, but it might be normal just because they're more or less in the same range. So it's always ideal to get a number. Again, if you feel crappy pulses, you probably are good enough to say, yeah, I need a fluid bolus right now. But if you're not so sure, and maybe the patient could be still in compensated shock, a number is a good starting point. And then we think about our tissue oxygenation. We get a little bit more fancy. We want to know the hemoglobin status, right? Because that's where oxygen is carried in the bloodstream. We would like to know the partial pressure of oxygen, the saturation, the SpO2 that everybody loves. Those are a little more secondary, okay? Prioritize those in your physical exam initially. So in compensated shock, probably very common presenting to you. They might have some mild mental depression. Sometimes they might be already tachycardic, but the pulse quality might still be normal, okay? And the blood pressure might be normal. Mucous membranes might be unchanged. Same with the capillary refill time. They might start getting a little bit more tachypnic to compensate. And then from here, we then move on to the decompensated shock, where they will be obviously very depressed, like that pit bull, obviously with hypotension. If it's a dog, tachycardic. If it's a cat, they choose whatever they want to do. Pale mucous membranes, increased CRT, and they will start getting hypothermic, like Pistachio was. Why do they get hypothermic? Poor perfusion, that's it. Everything is, and inside of the core, also, everything is already decompensated. Blood is not flowing normally in the periphery, so once you get a rectal thermometer, it's going to give you a low temperature reading. Remember that dogs are straightforward, and we know that if we have a dog in shock, even if the shock is now resolved, I expect that dog to develop gastrointestinal signs. Why? Because the gastrointestinal system is their shock organ. They bypass circulation from the GI to more important organs. Cats, as usual, make our life harder, and they do that with their lungs. That's why cats in shock are so much more prone to develop fluid overload, because they're squeezing all of that pulmonary circulation. You're giving them a ton of fluids, and then once the basal tone returns to normal, they now go into pulmonary edema. Everybody has been there. Have you ever heard of this concept, goal-directed therapy? No? Okay, great, so I can teach you about it. So when we talk about goal-directed therapy, it's a concept from human critical care medicine that they use when they are assessing patients in the emergency room, but also in the ICU. What it gives us is these 5 T's of assessment of the patient. This is a paper where they were applying it to perioperative patients that go from the ER to the operating room, but you can adjust it to any patient that presents to you. And initially, it starts by defining the target population, aka I have this certain patient, is this patient at risk of a certain type of shock or needing a certain urgent intervention, yes or no? If I determine that, yes, this patient needs intervention right now or is at risk, I determine, okay, when do I need to start that? Do I think that he's okay for me to step aside and finish that appointment, or he's not okay, I need to stay here and somebody needs to tell that client or carer that it's going to be a minute until somebody will be with them. Then I determine what type of intervention does this patient need. Is it a fluid bolus? Is it a vasopressor, a blood transfusion? What is it? And this to me is the most important bit, the target variable and the target value. What that tells me is that when I look at that pit bull and I say, yes, she's in shock, I don't know why, she's hypotensive, is not heart failure, I'm going to start a fluid bolus. I want you guys to start thinking already ahead and say, with this fluid bolus, I want her blood pressure to increase to X. And I want to go from a heart rate of this to that. Because if you don't have goals, when you go and you reassess your patient, you will struggle to identify, are you going in the right route and are you achieving what you must for him, or this is not working. So always have a target. I'm doing a medical intervention, I'm doing a prescription, this is my goal. Am I achieving that goal? Yes or no? If the answer is no, we probably need to readjust our intervention. So we have a lot of types of shock. These are the main ones. I hope that everybody has been more or less familiar with them, but if you haven't, today you will, okay? We'll start with the most common one. You probably see these at least every week in your practice, or every other week, I would say. It's the hypovolemic shock, which is very different from severe dehydration. Again, I used to work in a very busy ER, and all the interns, I would ask, okay, what are you going to do for this case? I'm giving it a fluid bolus. Why? Is it hypovolemic? No, it's very dehydrated. It's different, okay? Hypovolemia and severe dehydration are two separate entities. However, they can come along together or not. So if you think about hypovolemia, it means that inside of the vessels in your cardiovascular system, there was a decrease in volume. It doesn't mean that you're dehydrated. The classic presentation of that are the hemoabs. Suddenly you slice a big vessel or something ruptures, you start having a hemorrhage, so the cardiovascular system is quickly getting depleted. It doesn't give them time to get dehydrated initially, all right? On the other hand, if you think about cases like the ones that have been vomiting and with diarrhea for a while, the parvovirus puppy, the cat with chronic kidney disease that now forgot to drink during the summer and is super dry, they will probably arrive with severe dehydration with a degree of hypovolemia on board. But it's important to distinguish so that we can prescribe fluid therapy safely to one or the other. When you don't have hemorrhage associated with a hypovolemic shock, treatment tends to be with isotonic fluid therapy. So Hartmann's or lactated ringers, whichever you have available, Normasol is an option, Plasmolite is an option. When we talk about isotonic, we talk about a sodium and a chloride content as similar to the serum of your patients as possible. We don't like to use saline because it has a lot of salt and a lot of chloride. And in humans, it has been associated with worsening kidney function in critically ill people. So in veterinary medicine, we're humble. We wonder if that's going to happen to ours as well because their plasma concentrations are similar to us. So we switched also to lactated ringers or Hartmann's. And initially, we start with 10 to 30 mils per kg titrated IV boluses, all right, over 15, 20 minutes, 10 minutes, 5 minutes, push the bag if you need. Depends on how sick your patient is. And you say, have I reached the goal that I wanted with this fluid bolus? Because if the heart rate is the same or if the blood pressure is the same, I didn't. I need to keep working on this patient intensely. All right? Hypertonic solution is also very useful in these patients. Do you guys have access to hypertonic in your practices? Yeah, some of you. So basically it has a lot of sodium. And because it has a lot of sodium, not only it's going to give the volume that you give intravascularly, but it's going to quickly pull water from the interstitium. So it's going to dehydrate them on purpose to pull that water inside of the intravascular system. So it buys you time. Obviously, you need to follow up with isotonic solutions, but if you're in despair and you need to quickly treat this patient, is a good option. And then we also have plasma transfusions or synthetic colloids. We don't use synthetic colloids that much nowadays, so I'm not going to mention them just now. But we have plasma, which can be super, super useful, particularly for the patients that have a lot of protein losses through their diarrhea, for example. Again, the parvovirus puppy is a classic one, or the HGE ones. Now, when it comes to hemorrhagic hypovolemic shock, I say that yes, it's fair for us to consider an initial similar approach, but if this is what is coming out of your patient's mouth, as it was in this case, this was a patient that was receiving dialysis, probably for ibuprofen intoxication, and this is what he is actively vomiting, that's pure blood. As much fluids we are giving him, it's not going to replace what he's losing, right? So initially, it's fair to say that let's start with some crystalloids and see if we can regain a stability status. Now, if they are continuously bleeding, it's not going to be enough. And some people sometimes ask me, when do you know how to switch to blood or to give more fluids? I personally say that if I've given already a total of 30 mils per kg of isotonic fluids to a patient that is hemorrhaging, and that I know that is hemorrhaging, I say, okay, I've given him a third of his blood volume in fluids, and my target goals have still not been achieved. It's probably not working. It's probably time for me to say, we need blood. PCV, total solids, and lactate are useful, just for me to have them as a baseline indicators. Now, have I transfused dogs massively with PCVs of 38%? I have, because they're hemorrhaging in front of me. I don't really care if the PCV says 38%. He's gushing blood off his chest. I know he needs blood, okay? So this is good for us to then keep reevaluating them once they're stable, but you should not use numbers to treat patients. We treat animals, not numbers, okay? And if you can get an estimated blood loss, like sometimes the anesthetist gives you when it's coming from the OR, oh, I think that we've lost this amount, that amount, you can keep a closer eye on them. Your nurses will be more vigilant that maybe this patient will need a blood transfusion sooner rather than later. Moving on to obstructive shock. Is this familiar to you guys? Can you tell me what it is? I miss it dearly. It just goes to you, it doesn't come to us. But I do. Anyway, second question, can you guys tell me where is the caudal vena cava? Yeah, can you see it?
Just going into the diaphragm?
Yeah, it's right there, and then it disappears. And here we have this massive balloon. So GDV is a classic presentation of obstructive shock. And what happens, either with GDVs or with any other examples, is that it means that we have a large vessel that carries a great volume of blood obstructed. And if that vessel is obstructed, it means that that volume of blood cannot return to the heart. And if it doesn't return to the heart, it cannot cross the pulmonary circulation, be returned to the left heart, and then be redistributed. And that's how obstructive shock happens. In the case of GDVs that you guys see and make me jealous, is that we have these caudal vena cava coming here, and suddenly a big balloon there, expanding, 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 compressing it, and all of this volume is not going to be able to reach the right heart. And then the left heart is also depleted. Of course, that in GDVs, we also need to think about the amount of fluid that they get inside of the stomach, the amount of gas, etc. But mainly, it is a combination of obstructive shock and, to a lesser degree, hypovolemic shock. There are other examples. Anybody can guess what's going on here? I know it's a bit of a blurry image. Can you identify the organ? It's the heart, great. Perfect. And what cavity is this? Which ventricle? This is the left ventricle, correct, and that? It's not pericardial effusion. What is by the left ventricle? If we think about the heart. The right ventricle. This is the right ventricle. It's massively dilated. This is a poor image, but I could also tell you that it's hypokinetic. And the left ventricle has probably the space of my finger of blood volume going in there right now. It's very tachycardic, and it's very, very, very thickened in the right ventricle. Any guesses of what this patient is dying from? It's not. It's the right heart that made him sick. This is a classic scenario of massive pulmonary thromboemboli. This patient has a massive thrombus in his pulmonary artery. So when the heart tries to pump blood from the right ventricle to the pulmonary circulation, it's obstructed. So the right ventricle dilates because it cannot push it forward. If it doesn't go forward, it doesn't come down to the left side. So no blood comes to the left side. This is a big trouble. If you ever see this, please send this patient to me right away. I'll do my best. But yes, pulmonary thromboembolism, aortic thromboembolism, like the cats with ATE, vena cava thromboembolism, pneumothorax. It's another good example of obstructive shock. You have a chest full of air, and that air is true, does not allow us to distend the lungs, but it's also compressing the vessels. So once again, failure of the venous return. The management obviously will be very variable. As you can see, every condition can be quite different. Cardiogenic shock, also very common to present to you guys. Is this patient in heart failure? Who thinks yes? Okay, who thinks no? Who doesn't know? I'll help. He is in heart failure. See how fluffy the lungs are? I still cannot find a better English word to describe, but everybody agrees that his heart is large, okay? Has a big heart, so already one risk factor to be in heart failure. Let's imagine that we already know that he's dyspneic, okay, or breathing fast. And see how the image looks so fluffy up there, down here, down here. So there is already a little bit of alveolar pattern. This is pulmonary edema, okay? So yes, he's congested, he is in heart failure, and I'm going to tell you how to help him. So when we talk about heart failure, we talk either in systolic or diastolic dysfunction of the heart pump. They can coexist, but it's more rare. These patients, per definition, are hypervolemic. Why? Because if you go back into the physiology classes that we had when we were students, we know that because the heart is not pumping well, the kidneys are not being well perfused. So the kidneys say, I don't have a lot of blood flow here right now. Let me increase the amount of water I'm keeping in from the urine. So they have a lot of water retention. And the more water retention they have, the more hypervolemic they get. And then we have a heart with diseased valves or diseased ventricles. And all of that will then lead to them being congested and in pulmonary edema. If you are visual learners, like I am, I hope that this helps. But this is a normal heart, okay? A normal heart anatomy. We have the left ventricle, left atrium, right atrium. This is the aorta. when we have mitral valve disease, the left ventricle pumps, and even though, yes, we still have a good amount of blood going through the aorta, because this valve is now leaky, part of the blood regurges back to the left atrium. So the left atrium starts getting congested and the pressure increases. And if the pressure increases, the pulmonary veins struggle to drain in there. And so now the pulmonary veins are getting congested and are getting with increased pressure. And that keeps happening to the level of the pulmonary circulation, to the point that the pressure is just too much, and now it starts leaking. And that's how the edema will happen. Okay? Was that clear? Yeah? Now, if we talk about the classic cat with hypertrophic cardiomyopathy, it's a diastolic dysfunction of the cardiac pump, because they get really thick, and now the chamber is much smaller, so there is not a lot of space for it to promote diastolic filling. So because when they expand, just a little bit of blood comes in, well, I guess I need to pump harder because I'm just sending a little bit of blood to the aorta. So they're normally tachycardic, but because they also are failing into diastolic filling in proper aortic flow, we will also have a degree of mitral regurgitation, and the same will happen as in the previous example. What's the classic case for this one? DCM. Yeah, this is dilated cardiomyopathy, right? We have very, very, very thin myocardial walls. They're not strong ones. They cannot pump properly. So we have these very dilated, very big hearts that fail with their systolic function. And if they fail with systolic function and they're just dilated and dilated, part of it will also start being backflowed to the lungs. Pulmonary edema happens. How do we treat heart failure? Perfect. How do we not treat heart failure? Correct. Fantastic. Everybody gets a word. No fluids. It's bad, right? They're already drowning in their own fluids. So if we give them more fluids, we're just going to drown them even more. So we're going to give them furosemide. We're going to dry them, not drown them. Yeah? Perfect. So yeah, we want to promote them to pee all of that extra water they've been building up. So diuretics. We want to promote good contractility. Some might deserve more than others, depends on the contractility assessment on the echocardiogram. Pimobendan is probably a good choice for everybody. Listen to me. If you have a patient that cannot see a cardiologist and it is in heart failure, give it pimobendan. Just do it. And if you're in despair, you have this Doberman, he's super dyspneic, his heart is literally doing this, he probably deserves a little bit of dobutamine in his life until he feels stronger to get his oral pimobendan. If you don't have hypotension, and if you have either normal or borderline hypertension, vasodilators can be useful, but this is something that we tend to reserve on a bit of a more controlled setting, okay? Now, if you tell me, Marisa, I have this really dyspneic patient, I don't know what to do, and the blood pressure is like 170, I'll probably tell you to give him a little bit of a hypotensor, either a dose of amlodipine, a bit of nitroglycerin, etc., etc. And most importantly, oxygen, right? The alveoli are full of water. So the very few that are not, we want to increase the amount of oxygen that we have in there for them to absorb. So oxygen therapy. Distributive shock is another type. Maybe you guys will see it once in a while. Is the classic presentation of anaphylaxis. The problem with anaphylaxis is that it can be quite challenging for us to diagnose because there is not a specific test. It's a combination of physical exam findings and history. And in cases like these, we talk about relative hypovolemia because what's happening is that the cardiovascular system has lost its tone, particularly the venous one. So we have a pool of blood. These guys tend to have very quick CRTs, right? Because everything is, vasodilated, very pink/red mucous membranes. Septic patients, patients with systemic inflammatory response syndrome, Even though initially, yes, they do deserve fluid therapy, they will need vasopressors in their care. Fluid therapy on its own is not going to be enough because they need more help than that. And unfortunately, because they are so vasodilated, if we give them a ton of fluids, once again, if we regain that vascular tone, it's going to squeeze it and we make them promoted to fluid overload and pulmonary edema. So we need to be careful. What's this?
Gallbladder.
Yes. Is it normal?
It's anaphylactic halo of the gallbladder.
You'll get 50% off quotation because yes, it is a halo sign. We have gallbladder wall edema, right? It's very, very thickened. And of course that you're already cheating because I said anaphylaxis there. So now you're saying, oh yeah, and I see the free fluid, blah, blah, blah. Of course it's anaphylaxis, but it might be something else. What else could it be? A very, very potential and not so uncommon differential that presents to you guys. Pericardial effusion. Why? Because what happens in pericardial effusion is a degree of obstructive shock as well. Suddenly you have fluid accumulated in a very non-compliant sac. The pericardium is made to be there, right adhere to the epicardium. It's not supposed to have anything else. As soon as you have fluid in there, the pericardium cannot cope with it. It doesn't distend much. So if the pericardium doesn't distend much, then the heart gets compressed. And if the heart gets compressed and cannot, again, have a proper diastolic function, the venous return is compromised. If the venous return is compromised, there is increased venous pressure in the abdomen. The caudal vena cava cannot drain properly. And so that pool of blood can promote fluid extravasation because indeed they are in right-sided heart failure at that stage, and that can also cause gallbladder halo sign and peritoneal effusion. So before you look here and you say, anaphylaxis, got this, look at the heart, okay? If you have achieved this image, it says that you have an ultrasound, so there is no excuse for you not to use it on the chest as well. Okay? And yes, we have other differentials. They could be in liver failure. There are other very, very rare ones, but mostly is pericardial effusion and liver failure the ones that we want to make sure that we rule out. Now, if you see these and you say, oh, is this little dog, he's young and he looks okay, and he maybe takes Apoquel for his skin allergies, and now he like collapsed in the garden. And mom brought him over. You look at these, you say, I think that's anaphylaxis. The dog is pretty shocky. What do? You can say, I call you, which is good, but I want you to do something else before you call me. Yes, epinephrine, okay? Just like in the movies, EpiPen. So cool, right? You immediately give them epinephrine intramuscularly, and then you get on the phone for advice if you need so, or into your books if you're in despair. All right? Hypoxic shock, very common to present to you guys as well. Normally, and the majority, will be because of primary respiratory disease. Now, obviously, if you have a patient with very bad anemia, it doesn't have the transport of the oxygen, right? It's the hemoglobin. Or if you have cases that have been poisoned with paracetamol, or if you have patients that have been exposed to carbon monoxide in fire hazards, all of those have one thing in common, which is they benefit from oxygen. In the anemic ones, you also need to give them blood. But everybody here deserves oxygen. And I just wanted to go a little bit more in depth on the hypoxic shock because I recognize, at least when I was a GP, that I saw dyspneic patients all the time. When I talk about hypoxic shock because of respiratory disease, in my mind, to make things easier, I separate and I say, is my patient struggling because it's an upper airway obstruction or disease, or is it from his neck down, okay? And I'm sure that if we talk about the upper airway disease, we think about these, we think about these, Then we look at them like that. When they come in, and like, oh God, help. This is the gold standard of upper airway obstruction. But in fact, even if the patient is not intubated, and even if they come to you just for an ear infection check, what I would like you to always remember is that when you have these guys stepping inside of your practice, they are immediately at risk. Why? Let's go back to the triage concept. A, B, C. Where is the A here? Non-patent, right? So patients like these are always at risk of going into hypoxic shock very, very quickly. They just need to get stressed, start panting, off they go. Purple, right? So always keep that in mind. But it's not always the brachycephalic breeds. It's just like 99% of the times. But sometimes we see animals with laryngeal paralysis or something insane like these, where they manage to get the ball, which is rigid, inside of their throat, and now nobody can take it out. Patients with tracheal collapse, right? The Pomeranians, the Yorkies. So those are one of the main hypotheses that can present to you in hypoxic shock due to upper airway problems. And in these cases, I would say that oxygen, right? Always oxygen. Sedation. This is a suggestion, because it's the combo that I like to use in these patients. You can use others if you're more comfortable with others. Sometimes they will need you to intubate them and body cool them. The heat stroke Frenchie, he needs to be intubated at your practice. It's unlikely that he's going to arrive okay to my practice. But then once you've gone to that step, it's probably a good time for you to take a deep breath and get on the phone with us. Because now the dog is intubated and you're like, oh, OMG, what do I do now? And then we take it from there. Some patients will be okay after you cool them. Some patients will need a temporary tracheostomy. Some patients will not be able to leave the hospital without surgical correction. But that's the most important thing for you guys to deal with when they present to you. If on the other hand you say, no, Marisa, I'm pretty sure the dog's throat is not the problem, then I say, okay, most likely it's in the chest. And if the problem is in the chest, initially I recommend the same approach: oxygen, a degree of sedation if they're anxious. If it's a cat, it's always anxious. And you grab your probe, not your x-ray. All of you guys have ultrasound or not? So there is no excuse to x-ray them. And then you say, okay, first thing, is the patient in heart failure? Do I see B lines, big left atrium, etc., etc.? Yes or no? No? Okay, do I see pleural or pericardial effusion? Yes? Tap it. No? Okay, next question. You might need to go and take that x-ray now, because I recognize that looking at pulmonary disease with your ultrasound is rather challenging. And then, based on those findings, you adjust your treatment. If your patient is very dyspneic and very compromised, then it's probably also a good time for us to consider sending them where the respiratory care can be escalated if they need that. In any type of shock, we should be mindful that whatever it's causing it, the shock itself, going back to the basics, is developing because there is not enough oxygen to meet the cell's demand. So when we talk about how the oxygen gets to the cells, it goes through the airways, down to the alveoli, through the bloodstream, and then reaches the cells. That tells me that if any of these steps is compromised, my patient is at risk of shock. So in case of doubt, give oxygen, basically. Even if it's a GDV, they'll probably benefit from some oxygen, all right? Metabolic shock, hypoglycemia is the most common one. And then we have other options that are much, much rarer: mitochondrial dysfunction, situations like cytopathy of sepsis. Really is the hypoglycemia the one that you should be pretty comfortable with. Either the little puppies that just decided to get hypoglycemic that day. They don't need to have a disease all the time. Sometimes it's scary because it's been like 2 days and he's still on the dextrose CRI. Maybe he just needs a little longer. Maybe he's going to be fine. But puppies are a bit tricky. Or the diabetic didn't eat, or is going into remission, got its insulin, now it's seizuring. Small breeds of any age, they don't have a lot of reserves. They can get hypoglycemic easily. So if you have a patient with a hypoglycemic crisis, a dextrose bolus, followed by a CRI, while we figure out what happened, how can we resolve the inciting cause. And in cases where you say, well, it's already on a decent amount of dextrose supplementation, and it keeps being hypoglycemic, that's when I get worried. That's when I say something is off, and we should probably talk about that case because it doesn't appear to be a straightforward one. So in summary, if you have a patient that you think is in shock, don't leave it. Just stay there, assess your patient, and be quicker than that shock. So the same doesn't happen as it happened to Pistachio. We want to reverse the malperfusion, and we want to promote oxygenation in a variety of means that we just talked about. Fluids are the mainstay of treatment except cardiogenic shock. Never, ever in cardiogenic shock, even if they're super hypotensive, all right? And then remember your resuscitation endpoint. We want to achieve a goal, and if we are not achieving that goal, it's probably because I need to change my approach to this case, all right? Continuing to give more fluid boluses and more fluid boluses and more fluid boluses, it's not going to work, and it's going to cause harm, right? Remember, above all, do no harm, and we can do a lot of harm. It's not intentional, I know, but that's why the reassessment of these patients very frequently is so important. So, good job. Your patient is no longer in shock. Or maybe he's still in shock and you've done everything you could and you're like, I just cannot get this patient better. Now what? My suggestion is, call us maybe. We are there in our ECC team. There is always phones ringing, and we're always happy to get the phone calls to give you advice or just to have your patients transferred to our institution. And some of them, and if we think about the shocky ones, they probably deserve that, right? Because you were able enough to recognize, wow, this patient is so sick, arrived here in shock. We've dealt in the front line at the emergency work. We've optimized this patient, but it's very unlikely he's going to be fine to go home in a couple of hours or even tomorrow. And it's very likely that he'll benefit to be admitted to the intensive care unit. So this is where we come in. And we are very happy to take your patient for you, continue taking care of them to then return them to you. And that means that they get into the ICU, they'll have a lot of intensive care, a lot of nursing care, a lot of monitoring. They have criticalists with them a fair bit of amount of time, maybe the majority at these days, and they'll get whatever continued workup and treatment as they might require. And when we think about what does that mean being in the ICU, it means all of these, right? I'm sure that you're familiar, particularly for the ones that need escalated respiratory care. We're lucky enough to have a variety of options from the basic oxygen chambers up to mechanical ventilation. We can keep them on as many blood product transfusions for as long as possible or needed, the same for vasopressors. We have techniques for advanced vascular access. We can get them all the monitoring and fanciness that they might require. And we're very lucky because we have a hospital with a ton of other specialties involved. So when you transfer a case to the ECC department, that doesn't mean that if they don't benefit from internal medicine or cardiology input, they're not going to get it. We're lucky enough that we get consultations from everyone, depending on assessment of each patient. And this is what it looks like when your patient gets transferred to us. It just means a lot of intensive care in the ICU because we want to give them the best chances, right? You already did your best, and now we're going to try to do our best as well to get them back home and back safe. And that's it, and I'll take now any questions.